What I'm going to do now is actually read some case material and ask all of you to think about it for a bit. And I'm going to be repeating, when we have this discussion, some of what you're saying so that it will be captured on tape. And we're going to see how we can figure out level of risk for a couple of different youth and their presenting problems. Okay, we are beginning with Jose. And he is a 17-year-old. He lives with his mother, his stepfather, and 2 younger brothers. His mother's employed as a caretaker for a disabled woman. His father is employed in groundskeeping. Okay, so we have a 17-year-old living with his mother and stepfather. Both of his parents are employed. Now, some of the referral information in the history. It's the high school counselor who became concerned and suggested to the parents that they take Jose for some help. He's struggling academically. He has poor attendance at school and poor performance in school. He's been held back once, so he's 1 grade behind his age peers. He recently told someone at school he was thinking of killing himself, and that person passed that on to the guidance counselor. And when he was sent for an evaluation, here's some of the information. He struggles with mood dysregulation, substantial sleep disturbance. He reports a great deal of alcohol use. He reports continued stress around the death of his biological father and says he hasn't felt he could talk to anyone about it. He says his stepfather is not in support of him being here today and tells him to, quote, get over it and move on. He says, quote, I can't stand living anymore. The clinical diagnoses that they give him are major depressive disorder, alcohol dependence disorder, and possible bipolar disorder. A little bit of the family history. The mother shares that they have a strong sense of family, commitment to family, that she and his stepfather both have a steady history of employment. She does say she herself has been depressed for a very long time. Stepfather, possible alcohol dependence, and no problems at all reported in the 2 younger boys. How did he appear at the interview? He seemed to be his age, so he looked to be 17. He was polite. His thinking processes were logical. They were sequential, they were coherent, there was no evidence of any psychosis. He did show agitation intermittently during the interview. Okay, so let's just think about this for a minute. If you were trying to think of his level of suicide risk, and we had to scale this from 0 to 10, with 0 being, I have not heard a single risk factor of any kind, to 10 being, we have to do something this second. Would people just throw out some numbers? Where would you put this young man? Okay? I hear, okay, 8, 9, 5, 7. Okay, what are some of the reasons that he's not possibly lower than a 5? Okay, let's hear, what are some of the reasons that you definitely would not put him lower? Our numbers ranged from 5 to 9. Most of them were 7 to 9. What are some reasons? Yes.
Multiple potential diagnoses, including depression, family history of depression, lots of isolation and no support from the family.
Okay, multiple forms of psychopathology, depression, bipolar, also the social isolation. What are some other reasons? Yes.
The loss of a parent.
Loss of a parent, death of the father. Okay, what are some others? Yes. Suicidal ideation. Alcohol consumption.
Possible parental mental health issues.
Parental mental health issues.
Current agitation.
The current agitation.
Can't stand living anymore.
The statement, the ideation, I can't stand living anymore.
Exposure to a step-parent that is also dependent on alcohol.
Okay, exposure to a step-parent who's dependent on alcohol.
Also an older male.
He's an older male, so even though clinically we wouldn't, if it was an older girl, we wouldn't not go on and think of it all of it the same way, but he's an older male with these problems, and we're really getting quite concerned. Okay.
Sleep disturbance.
Sleep disturbance. There is more data coming out all the time as we have more clinical scientists studying sleep disturbance. And this was not included in the presentation, but there is emerging data on the problem of sleep disturbance in relation to suicidal ideation. I think when we don't get a good night's sleep, it's, right? Everything's harder. All right, any others? Yes.
Full signs of intermittent agitation.
Yes, okay. Intermittent agitation. So he has a lot of the risk factors. So one of the things that this is highlighting is, how complicated this becomes. None of these risk factors in and of themselves are a cause of suicidal behavior or suicide. So we don't have like a linear relationship. If this is present, you end up with this, right? Because most people who have those problems, they certainly do not kill themselves. However, when you start to have something where you're putting them together, and if you think about a transactional model of development across time, different risk factors in young people have a way of exacerbating each other across time. So that if you're, and some of this fits very well with a cognitive behavioral model, and the way we talk about downward spirals in a cognitive behavioral model, if you're failing in school and you start feeling worse about yourself, and let's say you start having thoughts of suicide and you're feeling more down, maybe you withdraw from peers, become more disconnected, or turn more to substance and alcohol use, then you might have more problems with mood regulation and with sleep regulation, and what we have is an exacerbation going on. Now, thinking of Jose again, what more would you want to know to feel like you had the information that you needed to really to get a sense of what you're going to do next? What are we missing? Yes?
To assess past suicide ideation, if he has at any other time thought of that and how recently he has.
Okay, so let's take this first one, which is we don't have any information here, a follow-up of that statement that he made. I can't stand living anymore. We haven't done an assessment of his suicidal thoughts, any current intent he might have, plans or preparation. We don't know if he's ever made a suicide attempt before, because remember, some of the suicide attempts young people make, the adults in their life don't actually know about them. And so we have to do that whole middle part of the risk formulation. We have to look at very closely in an interview, perhaps using some of these assessment tools at the current suicidal ideation and impulses. And I think we probably would have no idea what to do next without this piece. Okay, what else? What are we missing? Yes.
Has he had exposure to suicidal behavior in the past from the mother with a history of depression? So has she committed or attempted suicide, or has she had suicidal ideations that she's shared?
Right. So we would want to know about more about the family history of suicidal behavior and suicide. You know, we're left wondering how he fits in with his entire family in terms of a little bit more about the mental health history, if there have been other suicides. We don't know how his father died.
They would like to explore more how they're grieving as a family, or how he's grieving.
We might want to learn about their coping skills and where they are with bereavement. Yes?
I want to know about any recent trigger, like, so for example, whatever, was there an incident that triggered him to say, to express the suicide ideation? Like, was there any recent stressor or any recent conflict that
Right.
triggered that behavior?
Okay, so she is asking about, we don't have information. We want to know about any recent triggers. In other words, in what the information I shared about Jose, we heard nothing of a functional analysis of what's going on. Now, we don't have any evidence that he's engaged in suicidal behavior, so we wouldn't be looking at the antecedents and the consequences of the suicidal behavior, but we do want to know about his current life stresses and what triggered this statement in coming in for help. Perhaps he is being victimized. And victims don't generally feel good about, the bullies don't generally feel good about being the bullies either. Okay, what else? Anything else? Yes.
We know about his not supporting him, but who is his support system? Is there anyone?
Okay.
We know the father, stepfather is like, get over it.
Okay. Who is his support system? Where is he connected? Does he have one reciprocal friendship? Generally in the child and adolescent field, we're not so concerned about people having huge numbers of close friends, right? Because people are very different in their orientation to friends, but we do want to know developmentally if children have some reciprocal friendships that are stable. Okay, and as you're throwing them out, if you can make your statements fairly short, that will help with the taping, and I'll repeat them.
I'd like to assess too why they didn't do it, why they didn't commit suicide.
Okay. So sometimes what we do is have them scale their thoughts and the severity and use a motivational interviewing technique if you're familiar with those. And if they say it's a 5, you know, how serious were your thoughts or how seriously were you thinking about it, then we might ask, you know, I'm wondering what protected you, what kept you. I'm wondering why it wasn't a 6 or a 7, or why it wasn't a 2 or a 3. Okay, what else related to the risk factors that we've talked about? Yes?
History of abuse and sexual orientation.
Okay, a little bit more about his history. Physical abuse, sexuality, drug use, alcohol and drug use, his pattern of alcohol and drug use. Okay, so as we've talked about it some more, let's throw out the numbers again. Where do we put his level of risk? Okay, throw out some numbers. 0 to 10. 7. Okay, 7 with a lot of missing information because we don't have information about current suicidal ideation and impulses. Okay, we're going to go to another case. This is Sarah. Okay, Sarah is a 15-year-old girl. She lives with her biological parents. She's the youngest of 4 children, the only child in the home now. Both of her parents have professional degrees. They have a relatively high family income. And here's what brought her into care. It was an aspirin overdose, a pretty serious aspirin overdose. She told her parents, She was taken to emergency services where she felt very guilty. She expressed regret. She did this aspirin overdose on the anniversary of her older sister's suicide. This is actually someone who I treated. It has been completely blinded. So her history, depressive disorder, multiple symptoms, moderate to severe, lifelong history of social anxiety and depression, depressed mood. Okay, so this is moderate to severe depression, long history of social anxiety too. Her father was a retired professional on a medical disability. Her mother, a homemaker who struggled with depression. Her oldest brother was severely mentally handicapped and institutionalized due to a traffic accident. And her oldest sister was divorced and living alone, and her next oldest sister is the one who died by suicide. She is someone who paid a lot of attention to her appearance. She was a strong student. She was socially appropriate. There's nothing psychotic, notably depressed. Okay, let's think about Sarah. So on that scale from 0 to 10, where would we put Sarah? 8, 10, 9, 6. Okay. Anyone with a 5? Okay, so we have Sarah. What? 12. Okay, so Sarah's between a 6 and, did I hear a 10? 6 and a 10. Okay, so we have Sarah at the same or possibly higher risk than Jose. All right. Higher. Okay, higher. So now think about those evidence-based risk factors that we have talked about. Now let's look at the reasons that we think Sarah is perhaps at higher risk. Yes?
I believe the loss of her sister by suicidal, it would be a risk factor for her because she did the attempt when was her anniversary. So that's like something related to the data that you presented.
Okay. So her sister died by suicide, and as you probably noticed when in the earlier talk, in the overview, a family's history of suicide is a risk factor. It's some slightly elevated risk, because it's not as strong a risk factor as many of the other risk factors, but there is some elevation of risk, and this was the anniversary. She came in for help on this. Right? She told her parents, I want people to keep in mind, she told her parents she expressed regret. Okay, what are some other reasons we're feeling it may be higher?
I see a lot of losses. The brother who's disabled, their sister who's divorced alone, a lot of losses in families,
Right,
relationships.
right. She definitely has suffered a great deal with losses. And losses and trauma. Some of you, it's not our topic today, but you may know some of the trajectories of trauma, even quite severe traumas, and you're probably aware, if you are familiar with that literature, that most people do just fine. And that it's actually, it's significant minority, but it is a minority of people who go on to struggle after trauma. But she certainly has had trauma in her life. Okay, I'm going to look for some others who might suggest why Jose might have higher risk than Sarah. Yes?
Shouts pay attention to me because it seems like the family risk factors might be that mom's depressed, dad's paying attention to his own problems, sister's paying attention to her own divorce, brother's out of the picture. This girl's a good student, so she obviously wants to do well, wants to be recognized. So maybe she did that for a cry for help. It would certainly be noticed more if it was on her sister's suicide anniversary. So I'm not completely convinced without more information that was.
Okay. All right. So for a number of reasons, this could have been a cry for help. She's getting that help. She regrets what she did, that this might be someone where we do intensive treatment and continue to assess. And of course, as you might notice, if you're thinking about these, what I would encourage you to do is like imagine that you have the responsibility of the mental health professional who is caring for this young person, and evaluate your own level of anxiety and where is your threshold for what you would do with a youth like this. This young person, we did not psychiatrically hospitalize. We did work with her as an outpatient. Someone else might make a different decision. We don't have a good evidence base for that decision, except we don't have evidence that psychiatric hospitalization is effective in treating. It's effective in stabilization and evaluation, but it's not the case that you're going to be discharged from the hospital and have a lower level of depression, a lower level of loss in your history, or even a lower level of distress. It's really, as our hospitalizations have become quite short, they're really about stabilization, safety, and comprehensive evaluation. All right, any other thoughts on this one? Anyone else want to say why they might think her risk is lower than Jose's? And please try to keep your comments brief. Any others? Yes?
Jose had both MDD and the substance abuse, whereas Sarah only has one of those two, and it's kind of a nasty combination.
Right. So Jose has was diagnosed with alcohol dependence and with major depressive disorder, and he has severe sleep disturbance, and he's reported suicidal thoughts. And what we knew with alcohol dependence, we're really looking at a repeated pattern that it might be hard to get a grip on when it's occurring, when he's drinking, where he's drinking. He's 17. With 17, it's very difficult for the parents to monitor at all times the young person, right? So it's hard for us as clinicians to say to parents, you need to monitor them at all times. They can do this for 12 hours. But of course, if we think they're going to watch them 24 hours and not sleep, they are not going to be able to do it. Once young people can drive or have friends who will drive them around, which is very, very young, things are going on that the adults are unable to monitor. With alcohol dependence, someone could be intoxicated, become upset, and then you have a real high-risk situation. So they're both clearly, for the different reasons we've talked about, they're both at a moderate to moderately high risk for suicidal behavior. Sarah, I think what is helpful is the regret that she expressed, and that we have some treatments for the depression, and that she is, what you didn't know is that she was interested and willing and engaging in those treatments with both parents supporting that. But two cases, both with concerns here. Okay, we are going to one more, and this is Alicia. Alicia is a 14-year-old girl. She lives just northwest of Cleveland with her mother and a foster child sister. Her parents are separated. She attends a small private Catholic school. Her mother is employed. The family's socioeconomic status may be described as lower middle. The family places a strong value on good citizenship and education. She was referred for, quote, a depression evaluation. So this is a 14-year-old just outside of Cleveland. Her mother brings her in. What she has is a history of multiple severe depressive symptoms, all of them weeping, depressed mood, suicidal thoughts, self-hatred, constant fatigue, doesn't feel like doing anything, so you have the anhedonia, the loss of interest or pleasure. She feels guilty about everything. She can't concentrate well, so it takes her much longer to do her schoolwork, even though she does well. And what she said was she thought of, quote, taking a whole bunch of pills so I won't wake up. She describes herself as introverted and sensitive. Others described her as quiet, shy, and sweet. She has positive relationships with her mother and her sister. She works very hard at school and has 2 good friends. She's never received any mental health services before. Okay, so we have quite a severe depression in terms of a whole lineup of depressive symptoms. And we have someone who temperamentally describes herself as more introverted, as more cautious, as very sensitive. And I don't believe there was an assessment of separation anxiety and social anxiety, which could have been present. Family, strong family history of affective disorder, and this is perhaps what's notable about Alicia. In her family, there is substantial alcohol and substance abuse and suicide. Her mother was treated for depression and said she did a pill overdose, a suicide attempt, when she was a teenager. This mother has 9 siblings. There was 1 suicide, 2 bipolar, 2 depressive disorder, and 1 drug dependent out of those 9. That's 6 of the 9. The mother's aunt recently died by suicide. The mother's father was alcohol dependent and died young from cirrhosis of the liver. The father's father, Alicia's grandfather, was a drug use dealer who died in a homicide. The father's mother had a recent death from cancer. And if you look at Alicia's cousins, we have 1 older female with a suicide attempt that was pills and alcohol, and 1 of her male cousins recently died by suicide. Now, she has a lot of cousins, so I don't want to suggest, that's out of a lot of cousins because her mother has so many siblings. She actually presents she's very polite, very cautious, kind, affect, severely depressed, and tearful throughout. She feels unattractive, talked a lot about wanting braces. And the only time she brightened was when she talked of her two close friends at school. Okay, so this is Alicia, 14-year-old with severe depression who thought of, quote, taking a whole bunch of pills so I don't wake up. All right, where do we see her risk on a scale perhaps of 0 to 10? 3. 5. 2. 6. Okay, so here we have a range from 2 to 6, whereas when we were talking about Sarah and Jose, we had a range that was more like 5 or 6 to 9 or 10. So let's think about, why do we see her not being a 1 or a 0? And why did I not hear a lot of 2s? What is elevating her risk? The family history of suicide is slightly elevating it. What else?
Severe depression.
Severe depression is elevating it as much or more. Depression with the low self-esteem that goes with it, the sleep disturbance, the social connectedness is probably a protective factor in the sense that she's connected with her family and brightens when she talks about her 2 good friends, so she has some connectedness. any other things that you see as protective for her? Why not a 7, 8, 9 for her?
Doing well in school.
She's doing well in school. Of course, it's important to know that that wasn't one of our primary risk factors for suicidal behavior or suicide, because we also have very, very high-achieving young people who die by suicide and engage in suicidal behavior. But school failure can be a risk factor, so I don't want to, because it's often co-occurs with other things that are associated with elevated risk. Yes?
It seems to be no prior attempts and the description of the plan seems vague, so we want to do more probing, but maybe she hasn't really thought through what pills she would take and how many.
Okay. So we don't have, again, what is being highlighted is we're missing information. I think it would be fair to say that her risk may be somewhere between a 3 and a 10. Because again, what we haven't done is going back, we have not done the thorough assessment of her current suicidal ideation, intent, and impulses. So until we ask a range of questions about what are, I'm wondering what your thoughts are about suicide, about killing yourself. You've said that you have considered taking a lot of pills so that you won't wake up. I'm wondering how often you've had thoughts like that. I'm wondering how long they last. I'm wondering if you've had thoughts about doing other things to hurt or kill yourself. I'm wondering if ever in the past you have engaged in suicidal behavior or taken pills. With her, we might even do a behavioral interview because she is someone who is more reticent temperamentally. She's more cautious about what she shares. And then sometimes we have to ask very explicitly, I wonder if you have ever done this. I wonder if you've ever done this. I wonder if you've ever gotten out pills in the house to take them. If so, what kind of pills? And go through. I wonder if you have ever cut yourself or thought about cutting yourself. So we would want to get a much more extensive history there. And so we have to be careful. So sometimes we're at the end of an interview, or the young person has already left our office and we are left with the information we have. And then we have to make our best call on, here's our formulation, here's what our next steps are going to be. And one of those next steps will be getting that additional information the next time.